Hello, I am Dr. Patrick Lydon, Professor of Neuroscience at the University of California, San Diego Medical Center, and staff physician at the VA Medical Center. I'll be giving you basic instruction in examining and scoring patients using the NINDS-NIH stroke scale. After each set of demonstration and scoring instructions, I will guide you through some subtleties we've learned over the years. If that's helpful to you, feel free to click on the Special Features section of the menu page. They are excerpts from interviews with other stroke scale experts who provide excellent tips on scoring various items. First, let's discuss important general guidelines and ideal conditions for giving the exam. The value of stroke scale assessments depends on uniform examiner-patient interactions. Anyone who gives the exam needs to stick closely to the testing and scoring methods to ensure reliability and reproducibility of the results. Remember, the stroke scale is designed to measure the deficits seen in a group of patients, so some of the scoring rules may seem odd to you as experienced clinicians. If you follow these scoring rules, then the reliability of scores obtained in varying places by different examiners will be very comparable. All scale items must be scored. Record a score for each scale item before going on to the next one. If any item is left untested, a detailed explanation must be clearly written on your stroke scale form. It is important to use only the validated form available from the NIH. In the package you received with this disc, several websites are listed where you may download the correct version of the scale. Generally, we record the patient's first effort, even if follow-up efforts are better, to optimize the reproducibility of the scoring. Don't go back and change scores. The most reproducible score will be your first impression. Work methodically and quickly. An experienced examiner will be able to complete the NIH stroke scale evaluation in about 5 minutes for uncomplicated cases, though a difficult patient may require a bit more time. Each scale item is judged independently from the previous items. There are some exceptions, and we'll highlight those as we go. Now here are some important conventions used to assure the excellent reproducibility of the NIH stroke scale. Administer the scale items in their exact order. Avoid coaching the patient, even though this may be counter to usual clinical practice of trying to elicit the best performance. Accept the patient's first effort. Score only what the patient does, not what you think they can do. During the course of testing, you may develop an impression of level of function or lesion. Those impressions must not influence your scoring. Again, score only observed performance. Sometimes these rules don't make sense, but if all examiners do the scale the same way, the scores will be consistent. Be sure to include all deficits in your scoring, including those deficits that may result from previous strokes. Not all decisions are simple. When you're having trouble deciding on a score, try ruling out the extreme score and then weigh the mid-scale scores. You should keep the stroke scale reference material, such as the scoring guide, nearby when you administer and score the NIH stroke scale. However, at the bedside in a critical situation, all you need is the proper scoring sheet, the naming sheets, and a pin. These are the overall conventions. Now let's focus on each item of the scale. I will describe and perform each item of the scale for you and then go over scoring. Item 1A is the examiner's overall impression of patient alertness. Normally, you'll get enough information when taking the patient's history to make this assessment. Ask the patient 2 or 3 questions about the circumstances of the admission. Stimulate the patient by patting or tapping the patient, or on occasion, more noxious stimuli such as pinching may be needed to check the level of consciousness. Good morning.
Good morning.
Are you having any pain today?
Little pain.
Little pain? Are you comfortable now?
No, yes.
Okay.
For scale item 1A, this patient scored a 0. Let's look at how this scale item is scored. Score a 0 if the patient is alert and keenly responsive. Score a 1 when the patient is not alert but can be aroused with minor verbal stimulation. Score a 2 for the patient who is not alert and requires repeated stimulation to attend, or who requires strong, painful, or noxious stimulation to make movements. Score a 3 if the patient makes only reflexive posturing movements in response to repeated painful stimuli. A patient with a 3 on this scale item is generally considered to be in a coma. A patient suspected to be in a coma should be stimulated by rubbing on the chest or by using a painful stimulus. A 3 is scored only if the patient makes no movement other than reflexive posturing in response to noxious stimulation.
If it's difficult to choose between a score of 1 or 2, continue with medical history questions until you're confident in assigning a score. This is the only time you are allowed to go back and change a score. A score of 3 requires particular attention because it has an impact on how you'll score other scale items. In patients who appear to be in a coma and who score less than 3, you must attempt all items, but realistically, you will likely fall back on the predefined default values for coma patients. I will discuss these default values as we go along. They're also summarized in the scoring manual. You must choose a score, even if confronted with obstacles, for example, endotracheal tube, language barrier, orotracheal trauma, or bandages. Level of consciousness, item 1B, is based on the patient's answers to 2 specific questions, the month of the year and the patient's age. Would you please tell me your age? How old are you?
53.
Okay. And tell me what month it is right now.
February.
Okay.
For scale item 1B, this patient scored a 0. Let's look at how this scale item is scored. Score a 0 if both questions are answered correctly. Score a 1 if only one question is answered correctly. By definition, patients unable to communicate because of endotracheal intubation, orotracheal trauma, severe dysarthria from any cause, a language barrier, or any other problem not secondary to aphasia are scored a 1. Score a 2 if neither question is answered correctly. A patient who scores a 3 on level of consciousness 1A must be scored a 2 on this scale item. Aphasic and stuporous patients who do not comprehend the questions will score a 2. If the patient is in a coma, a score of 2 would be assigned.
Because this is a standardized test and to ensure reproducibility of results, other measures of orientation, such as time of day, location, etc., are not asked as part of this examination. But a patient who cannot speak may be allowed to write the answer. If the patient has aphasia, you need to judge his responses to questions in light of the language impairment. Like always, only score the initial answer. If the patient first gives an incorrect answer and then corrects himself, it is nevertheless scored as an incorrect answer. Many patients will give you their date of birth when you ask for their age. This is scored as a wrong answer. There's no partial credit for answers that are close, like being off by a month. For the third part of item 1, or 1C, you ask the patient to perform 2 tasks. Before beginning this assessment, be sure to position the eyes and hands in a testable position, then ask the patient to do these actions. Close your eyes for me. Now open. Now make a fist with your hand. You may repeat the command once, but do not coach or encourage. To improve reproducibility, score what the patient does, not what you think they are capable of doing. In general, you should try to pantomime the command so the patient receives your verbal as well as visual input. Close your eyes and open them up. That's terrific. Take your left hand and make a fist. And now open it up. That's great.
For scale item 1C, this patient scored a 0. Let's look at how this scale item is scored. Score a 0 if both tasks are performed correctly. Score a 1 if one task is performed correctly. If the patient does not speak English, a friend or family member can be asked to translate.
Now ask her to close her eyes.
Cierra tus ojos. Ábrelos.
Ask her to take this hand and make a fist.
This hand.
This hand, make a fist.
Aprieta tu mano así. Haz tu mano así. Así.
Make a fist.
Score a 2 if neither task is performed correctly.
Now I want you to take your hand and I want you to make a fist. I want you to make a fist. I want you to close your eyes. Close your eyes.
A 2 is scored for patients with a comprehension deficit and who perform incorrectly.
Some subtleties here. Give credit if a real attempt is made but not completed simply due to weakness. Only score the first attempt. Again, do not coach or teach. By the time this scale item is tested, you will have already interacted sufficiently with the patient to judge whether or not the patient will actually comprehend your verbal commands. If you're dealing with patients with trauma, amputation, or other physical impediments, you'll need to substitute other one-step commands.